record on this computer. Okay, so I basically chose this because uh, there's an ongoing campaign with advocacy as well, and this is kind of just a way to collaborate together as we also launch the Filipino Healthcare Workers Campaign in AFSA. Hi, Casey. Welcome to the space. Uh,
Uh,
Reminder, just going to reiterate this, but reminder that the topic that we're discussing right now is really heavy because we're talking about fatalities and deaths. So if you need to, mute yourself or like really not listen at some point or leave, you're welcome to do so if that's needed. Cool. Thank you, y'all. So this is a study published by the National Nurses United back in September 2020, um, talking about the deaths of healthcare workers and how the government and the healthcare industry or hospital industry basically are not being transparent with their data in terms of like fatalities of and conditions of their workplaces. Okay. Yeah. Okay. So this struck me this morning, this word, and for people who showed me or follow me on Instagram, this is something I shared. And we are actually in the January 2020 was the first case of COVID in the US, like first reported. And like it's been a year and there are already like 400,000 um deaths that were recorded. But one thing to take note is that it is actually more than 400,000. And that is because like there are cases that are not reported, and that's kind of like the main theme of the paper. And that's not just healthcare workers but also like different working class people, poor people as well are disproportionately affected by the pandemic. But I guess the overarching um, theme of the paper really is data and the importance of having the data. And as scientists, we are really trained to look at the data because it reveals the truth. And this is how we basically make sense of different phenomena like biological, chemical, physical, and even sociological, political. Um, and the truth, in its sense, would also give us power because there is power in facts, and data basically will give you the power in terms of like the knowledge of what is it that you want to change, and also the knowledge of how would you want to change it. So yeah, so it's important right now that we actually look at this, and this is going to be kind of like the flow of the discussion because we will be mainly discussing the the study, and that's going to be data and the truth. But also, we want to look at on the last part of the discussion how we could actually advocate for our communities, basing from the data that we are seeing, and how we could take back the power, because power in itself can also be taken by the others, um, in terms of like hiding the data, and that's kind of like the theme as well of this paper. I want to show this. I have a lot of introductions, but back in April, this is a very striking moment for me. While I was quarantining because I was alone, I didn't really know what's happening in the community, but I saw this news about nurses and other healthcare workers protesting at Mount Sinai and in Bronx. And I realized, shit, there's actually a lot of things happening in the hospitals, and I don't even know them. And it's not even like being reported in the media or by the healthcare system itself. So yeah, that's when I actually recognized that there was a problem in terms of like what's happening with our healthcare workers. And that's when AFSA actually had a healthcare survey for healthcare workers in New York City. And we had a few responses that tell us that they lack PPEs, and they need some support into like protections and making sure that they have hazard pays as they battle into like this pandemic and still needing to go to work. Um, so yeah, and so like this paper, which came out, it's in September 2020, is something that is really important as we continue that work in advocating for healthcare workers. So that survey happened in April 2020, but we never really followed up on it, especially particularly because we don't have enough people to actually do the work. And now that we have advocacy committee and they have like campaigns for, we have the campaigns for healthcare workers, this is an important data to look into. But also like for individuals, it's really um, it's it's kind of like a good way to actually see the situation more clearly. Like we hear the news every day about Filipino healthcare workers being affected and stuff like that, but we don't get the intensity of what's happening. So this is the paper. Um, and some methodology, if people would want to discuss and have comments on like methodology, feel free to do so. But this is kind of like the summary of the methodology. They basically collated fatalities of healthcare workers from media reports, social media, obituaries, union memorials, federal and state reporting, and the organization's internal reporting. So in this case, like they're healthcare workers, the definition includes registered nurses, nursing assistants, people who actually meet patients, but also those who are not directly involved in patient care. And then they have also attributed when a person worked or lived or spent time in a facility with known outbreak, they attribute their illness or infection or death to the outbreak in that facility. So they count that as well. And this is really not very complicated. It's a bit trivial. So if folks have comments, I guess yes, Miles.
Actually, I have a question. This might be a tangent, but how is it that they classify COVID deaths? Because like people will have that argument of, oh, it's a they had a pre-existing condition and that's why they passed away. Like it wasn't COVID that like killed him or whatever. And I try like when I have these conversations, I try explaining that you know COVID is exacerbating it where it puts them into a situation where they can't live because of it, or like whatever that pre-existing condition was just gets overwhelming. But yeah, how is it that they classify these COVID deaths and then uh, I didn't get to that part, but did they mention that and how they classified it for these stats?
I don't think they detail that in the study, but I think like for it's it's also important to be in the context that COVID tests are not even accessible during those times. Like from March to September, healthcare workers are not even like regularly tested. There's only like 24% of nurses who are getting tested. So I think what they do here is like if the person died and they're basically in healthcare workers and probably show some symptoms of COVID, they would count that as a fatality. Um, but yeah, I think that
Gotcha.
was. Mhm.
Thanks.
So yeah, moving on. Okay, so there are really just a few tables here, but I guess the important tables are like the first three, and I'm just gonna pass through the last three because those are mostly like statistics from other states. Um, so these are really striking numbers. If you look at the data so they have a different column for registered nurses just because like their organization is for nurses, but you could also see like the fatalities of other healthcare workers and the total basically on the last column. What's striking to me here actually is the number of fatalities in nursing homes. And I didn't hear that a lot in the media. Um, I always see like some news about, like the hospitals being overwhelmed and stuff like that. But it's actually also the nursing home residents and healthcare workers that are bearing the brunt of the pandemic. Um, I don't know if you folks have heard of this, and I've only heard about this too while reading the paper, but they said that there's a treat and place mantra in nursing homes that, like, if they get sick, they should just be treated in the nursing homes themselves. So I think that kind of like exacerbated the situation. Um, so yeah, and then what's also striking to me is like, because I live near a nursing home here, and I have few people that I befriended with, but they don't really have a lot of BPEs too in nursing homes because they're not in a hospital where it's like very knowledgeable scientifically as well and like how PPE works. They don't even know how to use the PPEs in nursing homes. So, yeah, like there's a lot of workshops on that with like workers, essential workers organizing, and there are some people who actually provide workshops for these people to know how they should wear the PPE, what's its importance, and how to actually advocate them for themselves. And so yeah, I think like from here, it's just the most striking thing to me because like I don't see a lot of folks actually advocating for nursing home workers as well.
I know that from the media that they would just talk about how the residents of the nursing homes were dying, but I don't think they've ever mentioned like the actual workers um,
Yeah,
dying from COVID. Yeah.
that is true. And then I think like another thing that kind of adds up to that is that these healthcare workers need to tend to these like in nursing homes they really need to tend to their patients too. I mean all do, but like um but like for nursing homes it's more there's still like there's more responsibility with that too. um do folks have questions? No, if not we could move on. Okay, so these are just numbers, and back in and as of September 16, 2020. So these are the COVID-19 registered nurse fatalities by state. And as you can see, New York, New Jersey, New York was the center of the pandemic during the early stages. So you would see that there's actually a very high number of um, cases of fatality around this area too. But yeah, and people were saying, or like in the paper, they were saying that the overall deaths by this time was actually 18,000, and New Jersey had 7,000. So there is really like an undercount in this because you like comparing 58 to 18,000. I think they think there were, like more healthcare workers that were gravely affected. And yeah, that's pretty much it. Like the data says it itself. Mm, but yeah, and then and this is also like another striking data in terms of the disproportionate impact of COVID-19 in different races, right? So as you can see here, Filipino healthcare workers basically comprise 31.5% of the death of all like healthcare workers in the US. And Filipinos only make up 4% of the registered nurses population in the United States. So it really says a lot in terms of like, how many people are dying. Mute someone for now. Okay, cool. So yeah, and if you could also see the Black healthcare workers are also greatly affected. There's 38 of the 213. This is just back in September 2020, who died from COVID, and that's kind of like 1/3 that's of the registered nurses of colors casualties. So yeah, a very striking number. Do people have thoughts or like things to share in terms of these data?
I have a question. So these are registered nurse fatalities. Does that mean that it doesn't include the healthcare workers that work in what you just mentioned,
Nursing
like
home?
nursing homes?
Yeah, no. Yeah, it doesn't include that. These are just also because in the data that they got for the nursing home centers, they only have like the number of cases, and I presume that they don't have like the race of the people detailed in that, so they just like took the numbers. But for this one, since their organization is like nurses, so they have like the data of like the race of the people. But also like based back from the methodology, it's the obituaries, social media, and stuff like that. So it's not even very accurate. But that's kind of like where these are the data that they got from all of those methodologies. Yeah.
I have a question, Carla. So the data that is collected here in this table, did you mention like if this was like in the US? Like is this in certain states, like all over the world?
It is in the US only.
Oh, so including like all of the states here.
Yes, but this is basically limited based on their methodology. So, as you could see later, I will have a slide on like the limitations and problems of these, or kind of like the hurdles that they had to go through for this study, because there is really no published, or there's really no transparent data reporting on like the fatalities of healthcare workers in the hospital industry, and even in nursing homes. So where they got this data are mainly from like media reports, social media, and obituaries and stuff like that. So there's still a lot of cases that are underreported here.
It's interesting to see white people on the top for me. I don't know why. I feel I just maybe because I'm from LA, where Filipinos are kind of majority of the nurses here, like people of color essentially are like take up majority of the nurses in LA County. So
Yeah, that's a good point.
That was weird for me too. Like, do Filipinos only make up 4%? Is that real? Like, I feel like everyone always, there's that stereotype. If you're Filipino, you're always encouraged to become a nurse, and like,
Yeah.
I'm sure we have a lot of nurses.
I would imagine it has a lot to do with the center states.
Yeah,
and actually, oh, sorry, Carla, go ahead.
Yes, Sheena, go.
Oh, okay. I was just sorry, one sec. I was just about to say, like, I've seen the data actually, like from the what's her name, Nina's Ponce, who is like the head of the public health policy department at like UCLA. She actually has access to like restricted data because like one of the major problems with even just like getting nurse fatality rate data in to begin with is that a lot of like the Filipino deaths tend to be obscured with just like overall like Asian deaths. And like if you just look at Asian deaths and think about like the proportion of Asian nurses, you know, they're about equal. But when you disaggregate that data and you divide it by Filipinos, this is actually an accurate number. Filipinos do make 4% of all registered nurses in the US. Like that is a known fact. But the fact that, you know, even if they only make up 4% of the whole nurse population, they are still accounting for over 30% of all nurse related deaths. Like that is a very, very huge disparity between like proportions versus deaths. And like she also mentioned that, yeah, and like Carla also mentioned this presentation, like the only other race where the number of deaths is higher than the actual proportion is Black people, but by a very small margin. The Filipinos really are like taking the brunt of like COVID right now. And then I think like another major question that needs to be asked is like, why is this? And that's when, you know, you start to take into account like all the systematic issues. And like, you know, like you guys are saying, like, you know, when I look around, like, I mean, we just see like not like POC nurses. And that's part of the problem because but like this has actually been reported, but like white nurses tend to be in safer areas of the hospital, whereas POC and particularly Filipino nurses tend to be on the front lines, like in the ERs, in the ICUs, where they are going to be like more exposed to COVID. So that is like part of the reason between like the juxtaposition between deaths and like proportion.
Yeah, thank you, Sheena, for sharing that. I guess like I have some things as well in like the historical perspective, and also like the culture that we have as immigrants in this country on how, you know, like it's also related to the systematic issues. But actually, Casey, I saw this video, you know, about like the history of Filipino nurses in the United States. But a lot of Filipino healthcare workers are actually in California. They're like 20% of the healthcare worker force in that state because yeah, just a lot of people move to California. But I guess like in total, in terms of like looking at the different states, yeah, we do only make up 4% of the registered nurses, and it is very alarming that we are, you know, like Filipino Filipino healthcare workers fatality comprise 1/3 of all the healthcare worker fatalities in the US.
Yeah, I 100% agree. I like what Sheena said, where she mentioned kind of like where specifically Filipino nurses tend to reside in like what unit if they, you know, are more likely than not the ones who are the frontliners, you know, being exposed to COVID and stuff. And it's interesting to think like why is that? You know, like do we feel that like we're like more or well respected when we're in a position like that compared to another unit, say like labor and delivery or something else that's not as demanding like ER? Is it like the pay? Like it's a good question to like think about as to like why they tend to um choose or be placed in these more demanding units like ER and stuff. So that's
Mm-hmm. Yeah, I do have. I saw this video before. I think that was back in May, where there was like a Filipino nurse that was interviewed, and he said like Filipinos don't really say no to jobs, and that's kind of like why they get exploited by, you know, like the people above them in terms of, you know, like you get this job because, you know, like I know you won't actually complain if you get this. But also it's really rooted in terms of like, wait, uh, of being immigrants as well, and how, like there's a lot of room for exploitation with the idea of you as an immigrant or an outsider in this country. And people tend to exploit that or take advantage of that in the workplace too. So yes, it's kind of
I
like
think I can speak to like the unit preference because I've just worked in a lot of different hospitals and nursing homes. A lot of the times, like Filipino nurses end up in like crit care because it's you need a specialized training to do it. So it's like the additional education is something that's interesting for them. But then also they have really good hours, and then the hours to pay ratio for critical care units is a lot better than like being on the floor 24/7. So for them, it's like they would much prefer doing 2 to 3 shifts of 12 hours per week, and then have the rest of the week for themselves and family and like community, than having like a full 5-day week. And then by nature of there naturally being more Filipinos in that unit, whenever they are working, it's like a small family unit because these units don't have floaters really. Like they kind of stay the same people on staff for PACU, ICU, crit care, like CCU. And they kind of form their own little like conglomerates in the hospital system. So they all know each other. They all have a bond that's stronger than like other floors. So it's a tie-in of like the people that they see working in these units look like them, and the way that they function is like a small family. And that's really conducive to how Filipinos work necessarily in the workplace. And then having that on top of a good pay and like flexible scheduling really exacerbates the reasons like why they choose to go into these fields versus like having a normal floor or like going to L&D.
Yeah, thanks for that, Natalie. Anyone else have comments? No, I guess like the next three, which are actually just it's gonna be here in one slide, is just okay. So table 4 is the healthcare worker fatalities by state, and this makes sense based on like what we mentioned a while ago about New York, New Jersey, and then these are the next other states that have a lot of fatalities: California, Georgia, Texas, Florida, and Illinois. The nurses, the association actually pointed out Florida, which is a state that really has a very problematic reporting of the cases, and even though they're reprimanded, they don't really care at all, and that makes sense with like the news that we heard back then about like Florida and not wearing masks and like people still going to the beaches. But that's pretty much it. And then there's also table 5, which details the infections by state. And you could see here some changes in terms of like the fatalities and infections. California is already like on the top of the infections, and then followed by Georgia, Florida, Ohio, and New York is kind of like lowering down in terms of like infections of healthcare workers during these times, or like from April to from March to September, I guess. And then lastly, table 6 shows the infection rates of the 16 states that actually sends weekly or bi-weekly reports of their infection cases. So as you can see here, there's a lot of states that are missing, and like New York, California. Oh, wait, California is here. New York, New Jersey are not here just because they don't report those infection rates, or maybe like there's still a lot of hospitals that don't actually regularly test their healthcare workers, and it's the healthcare workers themselves that actually seek out those COVID tests for themselves and for their patients. So yeah, and that kind of ends the results. Wait. So yeah, like just important message, and this is really a section in the paper, but there is really a widespread resistance in the hospital industry to transparently provide information of healthcare workers' fatalities, and this is they've been mentioning this in the study too. It's because, they don't want the hospital industry to be accountable to what's happening to their healthcare workers. But also, there's a lot of issues still in terms of like hazard pays. They don't, there's a lot of resistance in the hospitals to actually provide hazard pays to their workers. And there's a lot of news about like PPEs, even though like private hospitals who really have like a lot of money only provide like N95 mask for a week in some healthcare workers. So that's really terrible. And another thing that's terrible is that federal, state, and local governments actually do not compel these hospital industries to actually report data. So yeah, it's kind of like fucked up. And then there are also like inconsistencies with reporting. Like CDC reports a very like low estimate. Not They have the numbers, but the National Nurses United actually have a number which is 166% of the cases that are reported by CDC. And CMS, which is the Center for Medicare and Medicaid services, just like for the nursing homes, also are not transparent in terms of like the data that they give. They also did not require nursing homes to give data until May of last year. So there's a lot of data that are missing from March when we started the lockdown to May. And it's also important to take note that the lack of transparency in the hospital or like in the healthcare facilities endangers the community beyond the hospital because and this is like a very important concept as well in the MERS SARS situation before, because the hospital was kind of like the transmission spot for the virus. And this is actually the same situation with COVID. You hear a lot of stories of like healthcare workers not being provided with PPE because they don't actually work in the COVID-19 floor. But technically, like there are cases where people who are in pediatrics get the COVID, got the virus or was infected because because of the nature of the virus that was not even like recognized early on. So yeah, so there's really a lot of things happening, and it's not even like ending, like it's still happening. There's still a lot of data missing, and there's really a very like there's a lot of opportunities for people to actually advocate for our healthcare workers. And so I want to open the space for like people's thoughts. If you have oh, I'm gonna share some historical perspective afterwards, and also like we could have a discussion on like what we could do as an organization to advocate for healthcare workers. Your thoughts? Anyone has thoughts? Cool. All right.
I thought that was really good, Carla. And I feel like the data that you showed, there's still a lot of work that needs to be done with all of that, of course, like you said, with collecting data and being transparent. But I see, like, when you try to gather so much data, how I feel that it can be very easily like we obviously want this data to be correct, and like gathering this amount of data is so much, like sometimes I think that even just going state by state might even say more about something like this, because
Mhm.
when you try an entire country, I feel like a lot is going to be lost in translation, if that makes sense.
Yeah.
So I don't know, maybe as an organization, like start by states or communities, I don't know, and then build up from there. But I know how hard that can be. So it's a thought.
Yeah. I think that's a really good point. And that's something we could discuss with advocacy committee as well. In terms of like, well, we will talk about that in a while. So I'll just talk about it later. I'll just move on then. So, whoops, I know it's a lot. But actually, like all the details in this slide is in a YouTube video where I just like took the details. So it's a 7-minute video that you could watch, and it's more interactive. But like the video is from Al Jazeera and was it was just really a kind of like a video of why there are a lot of Filipino nurses in the United States. And it was like the details were based from this book by Catherine Zenisa Choi, which is The Empire of Care. I don't know if folks have already read this, but it seems like to be a really great book. They also interviewed the author in, like in that video. Anyway, so why are there so many Filipino healthcare workers? First, let's go back to it's 1898. But colonization is one, and it's probably primary. But as we all know, like the Americans colonized the Philippines. They did the Americanization of the country. They took over education. Um, and really built kind of like a US system in the country. So then that kind of builds up desire for the United States in most Filipinos. And I don't know if you know how very westernized Filipino culture is. And that's like really rooted in like colonization. But also during the Filipino-American War, malaria, or like when Americans were in the Philippines, malaria and cholera had killed several people. And so they had to train volunteer auxiliary and contract nurses. And that's how like the kind of like the nursing started in the Philippines. In 1903, there was a Pensionado Act, which basically funded Filipinos to study in American colleges. And then I have like a lot of comments with this, but these are actually like some of these programs are actually done to kind of like pacify Filipino resistance. It's like, oh, we're actually really good, like we will educate you, or like we're sending you to other countries, or we're sending you to America to educate you. And then in World War II, nurses were trained by the US military. So they were kind of like serving there as well. And then there was an exchange visitor program where people can visit the US and then train here for a while, and then some people just stay. And because of this program too, there's actually like there was a balloon, like there was a boom of like nursing nursing schools in the Philippines. So from 10, there were 429 nursing schools in the Philippines, and it's really growing. Like during my time as a high school student, a lot of my classmates went to nursing schools because of the idea of like migrating to other countries. And then so from 7,000 nurses in 1948, it rised to 57,000 in 1953, and that's just in a matter of 5 years. And to note, guys, in the Philippines, they said they're actually lacking nurses. So there's kind of like that, like irony of like we're actually producing a lot of nurses, but the Philippine healthcare system itself doesn't have enough healthcare workers. And then, of course, you all know the 1965 Immigration Act that kind of like helped people immigrate to the United States. And paved way for more people to come in. And also in the 1970s, the Marcos presidency allowed for or kind of institutionalized the labor export policy that encourages and trains people to actually leave the country and work abroad so that they could give remittances to the country and kind of like help with the economy. But really, it's, you know, like we are the number one provider of labor export in the world. But I don't know if number one really, but that's an exaggeration. But we do provide a lot of labor export around the world, and 7,000 Filipinos leave the Philippines every day to work in other countries. And in the 1980s, Filipino nurses were recruited as a solution to staffing shortages exacerbated by the AIDS epidemic. And I don't know if you all have stories, but I met a lot of titas who actually really came in here during this time with AIDS, and they were saying me, "Oh, this is nothing like AIDS, like the COVID situation." So you see how like all, you know, like Filipino nurses are really kind of like the defense in all epidemic, pandemic, or all kind of like, um, you know, um, different issues in the health of like the world basically. But in the United States, this is kind of their history. And this gives a lot of, but also like these things are still rooted in, you know, like poverty in the Philippines. There's not really like a lot of options for people to work in there. And that makes sense in terms of like why nurses in the Philippines don't actually work in the Philippines, because they're paid very less. And that's like 10,000 per month in rural areas. So 10,000 is actually how much? $200 per month. And you compare that to, you know, like the work. So it's still like very rooted to the economic problems and the situation and the social political situation in the Philippines too. And you know, and once you come here in the US as an immigrant, and people make you feel like you're an immigrant, you know, taking advantage of that identity, there's really like a lot of room for exploitation too. And we have tackled that a while ago about um, we don't really know how to say no, or we want to take those shifts where there's actually more pay because, you know, like we want to gain more money from the work that we do. um, but yeah, if people have other points to add on in here, or like just stories to share, but the last part would be some things that we could do, or like some calls to action. 1, 2, 3. Okay, no. All right, and so getting back, and this is like important, and this paper was really coming out from this article that we saw in New York Times, where, you know, like with the threat of the second wave, like how are nurses feeling, and how are we should be able to like advocate for them. And I think this tita works in Elmer's, Queens, and we actually have protested there before during the height of the pandemic, because this is like the number one hospital with a lot of like fatalities, and was very overwhelmed because it's a public hospital. So yeah, some calls to action. Of course, one is to educate ourselves, to learn more about our Filipino roots and history. But also, we have a campaign as an organization for Filipino healthcare workers, and you could join that through advocacy committees. And you don't need to be like a member of advocacy committee to actually take in and be part of the work. So only if you have free time, or if you're like really dedicated to the cause or passionate about this. But some of the things that the advocacy committee is looking is, you know, like how do we empower our healthcare workers to advocate for themselves in the workplace, yeah. And then so that includes like hazard pay. How do we make sure that they get the vaccines and have PPE, and also like, teach them how to actually, or what's the importance of PPE as well, especially in nursing homes. And we do have some contacts, or like nursing homes and hospital, or like nurses that we know in New York City and New Jersey, and that's kind of like where we wanted to start off, in advocacy committee. But if you're in another state, that's also fine, and you could help out with like a lot of like online things. But in terms of like New York, New Jersey, we so there's kind of like a lot of mutual aids that's happening, like even for food, or even for PPEs, masks, and face shields that we could also do in person. And then um, from advocacy committees meeting before, there's also a plan to really have a research group as well that will collate some data, and amplify the stories of our healthcare workers, and maybe also call for report transparency. Um, so yeah, we were looking into like sharing stories of different healthcare workers, and that could include other nurses and nursing home healthcare workers outside of New York, New Jersey. So there's a lot of room, of like making this project come into fruition. And then I think for the last part, Sheena could actually share this. Um, and you shared this in Slack. I actually forgot to put the link.
Yeah, no worries. I mean, it's kind of done already. So they already sent the letter. But yeah, it was like super tight because they were basically trying to get it in before the inauguration today. Yeah, but no worries. I mean, I can just like give you a background at the very least. So basically, the Filipinx AOE COVID-19, I don't remember what they're called, like Research and Response Task Force. This is like a collection of like the top Filipino public health disparity researchers in America. They basically started last December, and have been, you know, having meetings like every Tuesday evening, just about like, I don't know. I've personally never been to a meeting. I actually don't know really what they talk about, but generally, they've just been like, trying to do a lot of community outreach work together and trying to figure out like how they can help, like bridge that gap, especially like in light of, this like report that shows that like a majority of the nurse deaths are Filipino, like what can they do about it as healthcare public health researchers. And so in the last couple months, they put together this letter that they recently sent out to basically the members of the Biden-Harris transition team, because they had a connection, and I think her name was Dr. Marcella Smith. And basically in this letter, it highlights the disproportionate burden of the Filipinx community, and how, reword. It highlights the disproportionate burden of how much the Filipinx community has had to shoulder during COVID-19, and how that burden has just been like largely ignored. And in particular, that letter urges the Biden-Harris transition team to disaggregate COVID-19 data. So that plays really into this whole, talk with the healthcare stuff. They also urge them to prioritize multi-generational household members of frontline healthcare workers to receive the COVID-19 vaccine. And the reason for this is because, so as we know, a majority of the nurses in the front lines are Filipino, and one of the biggest fears they have is to bring back COVID-19 to their families. And a lot of us, right, like live with our grandparents and like children. And so it's kind of hard to just convince the government, like, hey, let's just give let's give the vaccine to Filipinos specifically. But something that we can say is generalize it and say, hey, let's prioritize the families that are living with elderly people and such. And so that way, we can we can protect our community, but also protect the communities or the families of like other POCs. And then finally, their last call to action is to have a representative who's Filipino on the COVID-19 Health Equity Task Force. like in the government. So those were the three things that they were hoping for, or they were asking for. And basically in like over the weekend, they were trying to collect as many signatures as possible. So I had like extended this to like all of the Filipino groups that I knew. And I think like at the end of the day, we managed to get like over 500 signatures. So fingers crossed, like, you know, we hope that like this makes some kind of splash. But we'll see like in the upcoming weeks what happens. You know, there's been a lot going on with the inauguration. But yeah, so that's the thing. And if you guys want any more information on the task force specifically, and if you want to get involved, I can also extend like my contact for the group, as well as like, you know, the types of like things that they do. And if you're interested, like maybe you can reach out and join a meeting or something.
Cool. Thanks for sharing, Sheena. Those are really great work. And yeah, maybe like advocacy committee can also like collaborate with them in the future, especially that we have this campaign ongoing.
Yeah, actually, have you guys reached out to Damayan?
To
Because there is a group specifically for Filipino migrant healthcare work, or like sorry, migrant like non-healthcare workers. It's called Damayan. And I think they are doing something very similar to this. So like if you guys could just like look that up and like maybe try and like contact them, I think they would, you know, appreciate like the cross communication. Yeah.
Yeah, cool. Yeah, I think I know the man too. Cool. All right. But yeah, coming back to this, I also like Casey's suggestion about, you know, like focusing in one state as well and like doing some data collection. And we could definitely suggest that to advocacy committee too. But yeah, other things folks want to suggest in terms of like how we could do this. If not, it's already 8:30. I don't want to cut you all up. But we lost like the two other participants. But can we take a photo for first journal club? If I will just say 1, 2, 3. 1, 2, 3. Cool. All right. Thanks, y'all. Thanks for joining Journal Club tonight. If you want to join advocacy committee's healthcare workers campaign, let us know. Or like there's a Slack channel. There you go. All right. Bye. Thank you.
Thanks, Carla.
Thanks.
Thank you.